on behalf of VACCELERATE, I would like to invite you all to this seminar, effectiveness of vaccination against COVID-19. I think there will be a focus on the Omicron variant here. And it's interesting because I believe observational data is a very important complement to the trials that is the main focus of the VACCELERATE consortium. We'll hear talks from Nick Andrews that will present data from the UK, Fredrik Kahn, who will present data from Sweden and the southern part of Sweden, Fredrik Lyngse, who will present data from Denmark, and Laith Jamal Abu-Raddad, who will present data from Qatar. And some of it is already published. I hope we also see some very novel data from the speakers. And it will also be interesting because I think you're using some slightly different epidemiological methods in analyzing the data. So Nick, please, let's start with you. Maybe just a brief introduction of yourself.
Yeah, sure. Thanks, Pontus, and thanks for the invite. So yeah, I'm Nick Andrews, statistician here at the UK Health Security Agency. I've been working for many years on vaccine effectiveness and safety prior to the COVID. And we published a number of studies, mainly using the test negative design through the pandemic. So yeah, I represent a team at the immunization department here. So I'll share screen and hopefully this will work. And just go to full screen. Oh, let's go up a few slides. Is that on full screen for can you confirm, or do I need to switch? It's fine. Okay, so yes, I'm going to give this talk looking at Omicron, but you'll see some Delta results as well of the COVID vaccines used in England, but focus on the Omicron. So I'll just launch into the methods. So first of all, I'm going to start on looking at our effectiveness against symptomatic infection. So this is using the Pillar 2. Sorry, I'm just moving some images out of the way. This is based on our Pillar 2 data, which is our community testing, which just stopped last week actually. It's used on sort of self-reported symptoms for them to then get a PCR, and it's I'm using the period from when Omicron first appeared, so back to end of November up until March the 3rd. So it's analysis 2 or 3 weeks ago. Just updating the analysis today, actually. PCR positives can't have been previously positive within 90 days, but we do allow reinfections if it was more than 90 days since a previous positive. Similar for negatives, for selection of them. We've got some different age splits, and in order to assign whether they're Omicron and Delta, we use a sort of combination of the sequencing, the genotyping, and also from the S gene target result, as well as the period itself. If the strains become dominant, then we can assume they're all that strain. So there's a sort of combination. I won't go through the details of those, but that's how I sort of split them. Vaccination status is through linkage to our NIMS immunization register, which is set up sort of for the specifically once the pandemic occurred. It's got denominator data, so it's got everyone, not just those vaccinated, and that has some quite useful information we can use for adjusting for some potential confounders. This presentation here is an update on the paper that got published on the effectiveness against Omicron a few weeks ago. The outcome is our test result, so it's test negative, 1 being positive, 0 negative, so it's by a logistic regression, the VE being 1 minus the adjusted odds ratio. We still are comparing in our primary analyses to unvaccinated. Beware, that's quite a small population in the older age groups in particular. But you can see waning. Even though the comparisons are always to unvaccinated, you can kind of look at the relative effectiveness by looking at the estimates sort of in 4 different vaccines and across time for waning. Vaccination is I've split by different intervals, and you can see the variables mainly that are obtained from our NIMS records. Some of it's also information recorded when people submit samples. So we've got a number of variables there you can see that we can adjust for. So I'll go straight into the results then against symptomatic infection. I'm showing you the results where the Pfizer vaccine was the primary vaccine, but the results are always similar once you're post-booster, certainly, for the effectiveness for the AstraZeneca as being your primary vaccine. And this is actually 16 and 17-year-olds, so these were only done with Pfizer. And the reason I've picked these is we can look at dose 1 and dose 2 with more data in this age group, because they were being vaccinated closer to the time of the Omicron wave. And so you can see the effectiveness against the Omicron declining from around 50% down to getting down towards nothing after that first dose by 25 weeks. It's boosted up to around 70% post the second dose, and then it's declining down to nearly 20. And then once we're after the third doses towards the right-hand side here, you see it back up to around 70%, but again, evidence of decline after those doses. With Delta, the VE was much higher. Some slightly odd Delta results after dose 1. I'm not quite sure why. That's pattern after that first dose. So that's then if I then go on to look at the 18 to 64 age group, then you can see here that the pattern, this is just looking post dose 2 and post booster, again against the Omicron coming from 70 down to around 20 or less after the second dose. And after the third dose here, you can see it goes back up to around 70%, a little bit higher for Moderna, and then it's declining again fairly quickly down to around 30. See, it's dropped a bit more once I go to 20 plus weeks. It's sort of heading down to not too different to that post dose 2 really. This is the over 65s. The pattern's quite similar. The numbers are a bit small after dose 2 because most of them hadn't been vaccinated recently with just a second dose. A lot of them had a booster, but post dose 3, you can see again a similar pattern to the younger ages, with that decline from around 70 down to heading towards 20 by 15 plus weeks. If we look at a comparison of BA.1 and BA.2, which I can do based on those samples where they were sequenced, then you can see here, this is usually all over 18s, you can see it looks very similar. We're seeing very similar effectiveness where we do have that split. If anything, the point estimates for some of them are a little bit higher for BA.2 than BA.1, but not much different. So we're seeing a similar pattern. So I'm kind of happy that I can combine the two together. They have obviously circulated. BA.2 has now become dominant, so they are kind of covering different periods, which makes a little bit of comparison a little bit difficult. I've tried to use the overlapping period as much as possible though. So that's that BA.2. So the black is the BA.2, so you can see very similar to the circle, the BA.1. I'll now go on to hospitalization. We just had our analysis went up on Medrix just recently, so it's not fully published, but it's available. So this analysis, I think, is similar to the one that's up there. So I've just pulled a few results out. We use a few different data sets, the emergency care admissions from Pillar 2. So someone goes for a community test and then gets admitted via emergency care. And that's the way we've been analysing hospitalizations throughout the pandemic up to now, is more based on our community testing going on to get hospitalised. But more recently, but partly because we know we're only going to have our hospital data pretty soon, we've been looking harder at this using the SUS, or which is an early form of our HES code hospital discharge data, where there's more coding. We can pick those that are respiratory coded, and we can look for admissions either from the community who then get admitted into hospital after a community test, or we can just use the testing within hospitals where a sample's taken around the time of admission. And again, we're using the Omicron period. We have to cut the data back a bit further because there's a delay in our SUS data coming through. and we need to allow time for the admissions to occur. So one thing I did do was have a look at the hospitalization, the VE, according to quite a few different definitions of hospitalization. So if I work from left to right here, you can see this is symptomatic disease. So this is a bit like the slides you saw on the pillar 2 symptomatic disease and assessment. So this isn't hospitalization, this is for comparison. And you can see that overall post the 3rd dose, it's around 60% with all the data. Obviously you saw that waning, but it's averaging out around 60%. If we look at using our emergency care data, you can see the VE this is in 18 to 64-year-olds, is around 80%, depending on which control group we use, whether it's all controls or those who were only those who were admitted, rather than all symptomatic controls. But you can see around 80%. If we use the respiratory coded emergency care data, so should be more specific, although not everyone gets coded, it's around 85 to 90%. If we then start looking in our hospital discharge data, one thing we did do is initially we pulled out everyone wherever their respiratory code was in their discharge diagnoses. It didn't have to be the primary one, and we could also look at how long they were in hospital for. And what we found was if we used those who had a very short stay, or we just used those who had a primary, who didn't have a respiratory as their primary code, the VE actually looked like our symptomatic cases against Omicron. And this is suggesting really you can't use these cases, these short stay in and out or non-primary coded, because they're almost certainly, the majority of them are not being hospitalized because of COVID itself, which is why the VE looks similar to our symptomatic, I suspect. Once you start getting more, a little bit more specific or serious, so at least 1 day stay, and it has to be the primary code, then 2, then 3, you can see the VEs going up towards 85%. If we require them also to have been on oxygen or oxygen ventilation or admitted to ICU, then we get a higher VE at around 90 to 95%. So you do get quite a difference. And this is, I think, a combination both of looking at a more severe endpoint, but also having a lesser chance of having incidental infections sort of contaminating that VE. So I then focused on that SUS data and the 2 endpoints, the one where we require them to be in oxygen ventilation and ICU, and also the one where it's at least 2 day stay. And this is 18 to 64s. And now I'm trying to look at whether there's waning in the different age groups. So here you can see perhaps some evidence that the VE post the boosters is dropping off in the longer intervals, less so for the more severe endpoint, but we're keeping an eye on this sort of period, 15+ weeks late after the booster dose, because that appears to be dropping off. Is it true waning, or is it still that having within these some who weren't admitted due to the COVID itself? Actually, if you look at the over 65s, there seems to be less of an issue in terms of things dropping off. This is the VE in the over 65s, and there's only a minor amount of waning against either of those endpoints after either the Pfizer or the Moderna, the boosters. So that's slightly surprising, because you might think, why should it look better in the over 65s? I don't know whether this is because more of the over 65s are genuinely in there due to the COVID rather than some other reason, but we are seeing that difference. I think that's my last slide of results. So I just conclude that we're seeing overall VE waning very quickly, pretty quickly against Omicron after each dose, including now the booster. It's higher against hospitalization, less waning, but we are seeing some, particularly apparently for the younger ages. And clearly those endpoints are important, quite how you define your hospitalization. So I think that's still an area to continue to work on, that we do discuss it in the paper. And thanks to the team here in the immunization department for all of the help and data extraction to run these analyses. So I'll end there, thank you. Shall I stop sharing for questions or keep it up?
You can keep it up, I think.
Yes, in case I need to go back, yeah.
Yes, exactly. And if you have any questions, please post them in the chat so then I can read them out, because I think it's only panelists that have access to being able to speak on the one. While there is one question coming up here. Do you have data on 50 plus for hospitalizations? I think you were showing 60.
I showed 18. I think I did play around with splitting the younger ages, and I found that the distinction in terms of the VE looking somewhat higher for the different endpoints definitely came in at 65. It was when I looked at 50 to say 64-year-olds, they look similar to the 18 to 64. So I think it's very much the over 65s that I was seeing a slightly different pattern in terms of the VE and the endpoints. So I did look, but I haven't kept that analysis. That was just when I was exploring why we were seeing this difference in VE by age that was a bit surprising for Omicron. I should say for Delta, I didn't show the Delta, but for Delta, which is in the actual publication, the VE is high whatever you use, and it really doesn't matter too much, and that's why we never worried about it too much before. But with Omicron, it seems to, and whichever age really, but with Omicron, it's certainly become much more of an issue, kind of how you measure that hospitalization.
Okay, thank you. There's another question with regards to more the implications of your findings for the impact of a second booster policy in the UK, and maybe reflect on infection versus hospitalization.
Yeah. Sure. Well, you might know our policy is 75 plus that's already come in, and JCVI are keeping an eye on and looking at the data in terms of whether other age groups could be considered. It's 75 plus, and I think under 75 is in risk groups, and that's really based on wanting to, as you saw, the waning, but to get that VE back up as high as possible, particularly if there is some waning against this more serious infection, because we don't know for sure how that's going to change. But yeah, it's very much about the hospital endpoint rather than infection, because we can see, I think even if we gave another dose, it would drop off again in terms of infection. So I think for the Omicron, at least, it's wouldn't be used to try and control infection. But certainly it's all about severity, and we still do see our highest hospitalization rates in the oldest, in those in risk groups. So that's the key factor that's around getting those extra doses.
Thank you very much for this presentation. I think we move on to the next presentation, which is Fredrik Kahn from Sweden.
Yes, thank you. And I will share my presentation. Let's see. So, thank you for inviting me, and thank you for letting me share my results. My name is Fredrik Kahn. I'm a senior consultant in infectious diseases at the Department of Infectious Diseases at Lund University Hospital in Lund and Malmö, and at the Lund University, the Division of Infection Medicine. So I will present some of our data on Omicron and Delta, which is part of our initiative, which is called COVERS, the COVID Vaccination Effectiveness, Risk and Safety Trial, which is really a huge effort in the southern part of Sweden, in our county. This is my conflict of interests, and COVERS consists of 4 different work packages, where we mainly will discuss work package 1, the register-based study. There are also other work packages where we follow patients who came and donate blood, and we follow serology and cellular immunity over time and link that to our registers, and also vaccine failures and adverse events work packages. Let's see, and Skåne is then a county in the most southern part of Sweden. I think my colleague Frederik is sitting here in Copenhagen, just opposite. And Skåne is a county of 33 municipalities, different hospitals served by 1 clinical laboratory in microbiology with a population about 1.4 million. So we have made different cohorts here. The main cohort is then that we have a closed cohort that was formed of all people living registered in Skåne at December 27, 2020, when the vaccination started. And to follow vaccine effectiveness, we have a case control match study. Out of this cohort, the methods were published previously in epidemiology and infection. Mainly, we have the regional healthcare registers, where we have the ability to directly access all the electronic health charts from all the hospitals of all persons living in Skåne. We then link that to the national registers for communicable diseases and the national vaccine registers. So by doing so, we can follow the vaccine effectiveness, have a case control match where we match each case testing positive with 10 controls matched for age, sex, and calendar week that has not tested positive the same week or 3 months before. And we then weekly update it. So this is how the vaccination effectiveness on testing positive was for up to week 44, that is the beginning of November 2021. So we followed weekly, and this was then previously published, and then Omicron came. And we saw that and we define in this, we define in that we have continued to do it for the publication. I will show you also that to be vaccinated, we define as 2 or more doses. Then came Delta and Omicron started to appear at that time point, and we wanted to study the impact that Omicron had. So what we did, because in Sweden not all strains are sequenced on an individual base, so we had the periods instead. That we saw that we had the transition period, we had the pure Delta period, the transition, and then almost a pure Omicron period. So what we did, we went in and looked at the different period, excluding the transition periods, and then switching to a cohort study where the cohort consisted of those testing positive and looking for if they would develop a severe disease. So we then had a period from week 27, that is in the middle of the summer, until week 1, 2022. And then we waited some more weeks to let the person infected becoming severely ill so we could monitor that. So giving them time. And defining severe COVID, as Nick told, is not that easy. I mean, you could define like we have intensive care registers, but I know that, for example, in Germany, the beds in intensive care are 10 times more prevalent per 100,000 that is in Sweden. Even in the hospital in Skåne, the criteria for being admitted to intensive care is very much different. Do you treat people in non-invasive ventilations, your ordinary ward? Some hospitals do, some don't. Do you have high flow nasal cannula on your wards or don't? That differs between cities, hospitals, and countries. So we didn't think that was, we wanted to have something more robust. Then we thought of looking at the diagnosis, and that is, of course, a possibility, but as a physician, I know that coding is maybe not the primary interest of all physicians. So quite a lot are wrong coded. So we actually went into each person's health chart and looked what kind of oxygen they had in their surveillance charts and how much, and defined a severe disease of equal or more than 5 liters of oxygen per minute, admitted to hospital for more than 24 hours. And that was the outcome that was defined as a severe disease. And then you can see that the severe disease differs among the different periods. This could, of course, be due to different populations infected during different periods. So we needed to adjust for that, which we did with a logistic regression, adjusting for age, sex, and underlying medical conditions. And those conditions were those defined by the CDC. And to get hold of them, we went into every person's chart and looked 5 years back if there was any of these codes in the charts. So looking at the unvaccinated then, which really was defined as actually 0 or 1 dose, but those in 1 dose were a very small fraction of it. You can see the higher risk of getting a severe disease provided you tested positive is colored more red. And looking at the Delta period to the left, you can see that there is quite more red, both among women and men, than compared to the Omicron period. Looking at the vaccinated, you see the same pattern with more green on the Omicron side with a less risk of developing severe infection. However, still, even among the infected, the vaccinated people, elderly men with multiple risk factors still have a substantial risk of getting a severe infection. And yes, of course, that's comparing those two. You can see the unvaccinated and the vaccinated with a very much higher risk if you test positive to develop a severe disease if you are unvaccinated. This is the underlying, some part of the underlying logistic regressions where you can see, of course, that the Omicron has a less odds ratio, even so much more against among vaccinated. We have the age, which is, as expected, rises, the risk of severe disease rises with age. Women had less risk of a severe disease. Comorbidities increases the risk. The more comorbidities, the more risk of developing a severe disease. And the prior SARS-CoV infection, since we looked for that also, we can see that among the unvaccinated, a prior SARS-CoV-2 infection protected against a severe disease. Looking at effectiveness, we then went back to our case control and looked at it, and the protection against testing positive almost, or it completely disappeared once we got into the Omicron period. So here the protection, and of course this is a mix of 2 and 3 doses. So we couldn't really exclude from this that there might be some protection of those immunized 3 times, but that was a quick shift here. So the trend is very clear. However, the protection against severe COVID was still there. And this is our definition of severe COVID. The protection still remains, and it quite nicely fits with Nick's figures about 90% for those 2 days and oxygen, ventilator, and ICU. We see approximately the same effect here. Here is it monthly updated because of the less cases. And you can compare those two. We have actually, we continue to monitor it, and I will show you some unpublished data before we publish continuously on our homepage, new data as it comes out. First, I would say that the conclusions are that in average, it's a milder disease among vaccinated and among unvaccinated, but it is important to remember that Omicron continues to be a threat against populations and groups with low level of vaccination, especially those with multiple risk factors, and that vaccination continues to give a good protection against severe COVID. This is the new data, which is still unpublished. It is published on our homepage, and we will continue to monitor it more, but this is how it goes. And we see a slight decrease in protection. This is as time goes by, and we will analyze it further and divided it into 2, 3, and 4 doses to really see I mean, more time has elapsed, and that could be a time effect also. By that, I want to thank you, my co-scientist, Jonas Björk, Professor in Epidemiology, Malin Inghammar, Associate Professor in Infection Epidemiology, Ulf Malmqvist, Associate Professor in Clinical Pharmacology, and Magnus Rasmusson, Professor in Infection Medicine, all at Lund University, and the other co-workers in the project. By that, I thank you, and we'll be happy to take some questions.
Thank you very much, Frederik. Waiting for people to ask some questions in the chat. I was wondering, if I understood it correctly, you saw a difference in the increasing risk with comorbidity in unvaccinated and vaccinated. It appeared to be a higher increase of risk there. Yeah, exactly. No, that the next slide, that one. When you're looking at comorbidities, you see the odds ratio is higher in vaccinated. Have you been able to look at the immunosuppression at all as a is that the reason, you think, or what do you think is the reason for seeing that?
I'm not sure. We have the immunocompromised and immunosuppression. That might be. What I also think is that, I mean, the odds ratio, the background odds is, I mean, there is a 10-fold difference here. I mean, you go up in the odds. Maybe it's like that. If you're unvaccinated, the risk goes up so much, so maybe one risk factor is enough with age, and combined with that, I mean, the increase might not be so much. If we look at the unvaccinated, the risks are quite high already here with one risk factor. I think that is something. I mean, looking at all the men with risk factors, you're over up to 40% already with one risk factor if you are unvaccinated during the Delta period. And it might be, but of course immunosuppression might, and we haven't looked at it. We will be able to do it. The figures will be probably small, so I don't think the estimates will be that robust.
Thank you. There's also a question about the second booster in Sweden. For which age group?
Currently for 80 plus. And at that time point, I don't think there was there wasn't a second booster at that time point. That was later. So there was people having a first booster, but not at that time point. Now it's up to, it's a second booster for those over 80 and with risk factors, certain risk factors.
Okay. Thank you very much, Frederik. Then we move on to the third speaker, which is Fredrik Lyngse from University of Copenhagen, presenting data from Denmark, and I think a little bit more on transmission.
And I hope you can see the slides now.
Yes, we can.
Perfect. So yes, I'm Frederik, and I'm from Department of Economics at University of Copenhagen. And I'm going to tell you about our paper on transmission of SARS-CoV-2, Omicron variant concern, subvariants BA.1 and BA.2, evidence from Danish households. And it's joint work with co-authors from University of Copenhagen, Statistics Denmark, Statens Serum Institute, and the Technical University of Denmark. First of all, slide on conflict of interest. I have none, and my co-authors have none. So giving some background on the Danish setting. So this is a project where we include cases from December and January. So from here, you see the graph from start of December running on to 10th of January. And red down here is BA.2. And then you have BA.1 in the middle, and the purple is the Delta. So we only include primary cases for our study from the 20th of December to the 10th of January. And as you see, we have full support of both variants throughout our period. So this is why we choose this period. So setting, we look at households in Denmark, and they have to have between 2 and 6 members. So we exclude, for example, nursery homes for elderly people, and these 2 to 6 member households are relatively comparable. We exclude every household with a previous infection in the previous 60 days. So there's no BA.1 reinfections for the BA.2 cases. We only include primary cases who are tested positive between the 20th of December to the 11th of January, and we have whole genome sequencing on all of them. We follow the household contacts for up to 7 days after, so that's up to the 18th of January, and we close the data on the 21st of January. And then we exclude all households with co-primary cases, so that's if there's more than one case testing positive on the same day. So when we cannot designate the right primary case. So they are just excluded the full households. So this gives us just a brief overview, a secondary attack rate in these households. For this period, we see that for the Delta, we have a secondary attack rate down here. And then we have BA.1, which is more transmissible than Delta. And then on top, we have BA.2, which is significantly more transmissible than both BA.1 and Delta. This is just to set the stage. So going into the summary statistics, what do we do and what do we have? So first of all, we have 2,122 households with BA.2. So that's primary cases with this. And they live together with 4,587 contacts. And of these, 1,792 of them test positive, which gives a secondary attack rate of 39%. Secondly, we have BA.1 households where we have 6,419 primary cases, and they live together with 13,000 household contacts, and of these 3,900 test positives, which gives us a secondary attack rate of 29%. So this is exactly what you see here. Also, we have the 29% secondary attack rate for BA.1 households and 39% attack rate for BA.2 households. And we see it's increasing over time from 1 day to 7 days after the primary case tested positive. So next, of course, there's a lot of other variables affecting this. So we put it all into a logistic regression model where we have several adjustments. So first of all, we control for if the primary case was infected with BA.2 or BA.1, and then we include the vaccination status of the household contact, so that's the susceptible person or the exposed person, and we include the unvaccinated, fully vaccinated, and booster vaccinated for them living in BA.2 households, and the same 3 categories for them living in BA.1 households. Similarly, we do the same for the primary case, so the exposing case. And we have the same 6 groups there to look into infectiousness. And contact, household size, and primary case sample date, as these cases and households are running from 20th of December to the 10th of January, which is over Christmas and New Year's, which makes a bit of a mixing between normal household members. So first of all, we look at the effect of vaccination. So here we looked at the susceptibility to infection. So we compare the vaccination status of contacts living in BA.2 households. And down here we see a slightly increased susceptibility for unvaccinated and a decreased susceptibility for booster vaccinated. And when we do the same by looking at vaccination status of contacts living in BA.1 household, we see an increased susceptibility to infection in unvaccinated and a decreased susceptibility to infection in booster vaccinated compared to the fully vaccinated. Next, when we go into the infectiousness, so this is the infectiousness from the primary case, we compare the vaccination status of the primary cases living in the BA.2 household, and here we see a slightly increased infectiousness among unvaccinated and a decreased infectiousness among booster vaccinated. And when we do the same in BA.1 households, so here we compare the vaccination status of primary cases living in BA.1 households, we see a decreased infectiousness among booster vaccinated individuals. So to sum up, this is just to give the baseline that we have different baselines across the different vaccination groups. So we see that vaccinations do reduce the susceptibility to infection in context and boost us even more. And we see that vaccinations reduce the infectiousness in primary cases and boost us even more. So this is just a baseline, remember this. So if we want to disentangle what is immune evasiveness and what is basic transmissibility, we can think of this as looking about the basic, the effective reproduction number, RE, but this is this is equal to the basic reproduction number, R0, but times the immune evasiveness. So if we think about this, it's like if we see an increased transmissibility, we don't know if it's an increased basic reproduction or immune evasiveness. So this is exactly what we've tried to disentangle. So if you think about individuals with some immunity protection, so that could be previous infection or vaccination, we cannot separate the effect of R0 and the immunity protection. However, if you think about individuals with no immunity protections, then we have that the RE equals the R0. So combining this setup allows us to disentangle the effect of R0 and the immune evasiveness. So this is like the way we think about this. So next, if we go into the relative effect of BA2 versus BA1, so here first we look at the susceptibility. So we compare unvaccinated contacts living in BA2 households with unvaccinated contacts living in BA1 households. And as you see down here, we have an odds ratio of 2.2. Similarly, we can compare fully vaccinated contacts living in BA2 households with fully vaccinated contacts living in BA1 households. And here we find an odds ratio of 2.5. And lastly, if we compare booster vaccinated contacts living in BA2 households with booster vaccinated individuals living in BA1 households, we find an odds ratio of 3. So as you see, we have an increased odds ratios across the board, but also slightly increasing with the higher vaccination rate. So if we go into infectiousness, here we can compare unvaccinated primary cases living in BA2 households with unvaccinated primary cases living in BA1 household. And here we see an increased odds ratio of 2.6. However, when we compare the fully vaccinated primary cases living in BA2 households with fully vaccinated primary cases living in BA1 households, we only find an odds ratio of 0.6. And lastly, when we compare the booster vaccinated primary cases living in BA2 households with booster vaccinated primary cases living in BA1 households, we find an odds ratio of 0.6. So to sum up, we find that BA2 is inherently more transmissible, and BA2 also possesses some immune evasive properties. So to conclude, we would say vaccines work. So this is like a baseline measure for infectiousness and susceptibility, and booster shots works better. So this is that we find that these unvaccinated individuals are more susceptible to infection and more infectious, while booster vaccinated individuals are less susceptible to infections and less infectious compared to fully vaccinated individuals. But we also find that BA2 is inherently substantially more transmissible than BA1, and BA2 also possesses immune evasive properties that further reduce the protective effect of vaccination against infection, but do not increase the infectiousness from vaccinated primary cases with breakthrough infections. And that was 10 minutes. So any questions are welcome.
Thank you very much, Frederik. Let's see, there's a question from Sweden from Fredrik Kahn. Was there any difference in populations affected by BA1 and BA2? If so, did you adjust for young children which are unvaccinated and probably have closer contact with the other in the household? So
yes, so this is an extra slide on this, and here we have the BA2 households and the BA1 households, and I would say they are relatively comparable. So we have 50-50 males, females, and you have like the age groups down here, 17, 18, 14%, 17, 19, 15%. So that looks relatively okay. And also over here on the household size and the vaccination status. So from an observational study, I think this is relatively good. And did you adjust for young children which are unvaccinated? also, so this is where if we look at the primary cases being the young children, there we can also see, I think also we have something about age. No, not here. But we did adjust for age, and also we have here where if this is just the raw secondary attack rates, where you have the children for 0 to 10, for example, and they have a secondary attack rate of 65% in BA.2 and 43% in BA.1. So this is yeah, they are definitely less vaccinated in Denmark as well. I hope that answered the question.
Yes. Then Nick actually writes that they've seen similar vaccine effect in the analysis for BA.1 and BA.2. And you write, I wonder if the household study result may relate to the high level of exposure in households compared to other settings, i.e. multiple chances for immune evasion.
Yes, I totally agree on that way of thinking about it. I think like household settings are probably the most intense exposure that you can have. But if you think about household exposure to BA.1 relative to BA.2, so we only think about this comparison, I don't think there's reason to believe that they would be very different. So like conditional on you having a primary case coming in, we don't believe that the primary case could choose to be infected with BA.1 or BA.2, and the exposure should be relatively similar. But compared to being in the supermarket for 10 minutes or going for a jog and meeting someone, totally agree that this is the most intense exposure. And also if you sleep in the same bed as your partner, maybe breathing right into your face for 8 hours at night.
I had one question. Do you account for negative tests also in your analysis here, or you're just using the positive tests? Because I think you have access to that in Denmark. I just
so yeah. So this is the probability of obtaining a test. So after the primary case test positive on day 0, and down here we have the blue one is BA.1 and the red one is BA.2. So that's the probability that the household contacts are being tested, and they are relatively similar and also being tested twice. Yeah. And of course we could restrict them to be tested, but that's restricting on an outcome, which is onto the same exposure. So yeah, but we also have access to the negative tests. Yeah.
Thank you very much for that presentation. Then we move on to the last speaker, which is Laith Jamal Abu-Raddad from Weill Cornell, Medicine-Qatar, Doha.
Thank you very much for the kind invitation. Are you able to see my slides? Great, thank you. Yeah, so I am an infectious disease epidemiologist who have lots of interest on vaccine and natural immunity. And we have been doing a series of studies on COVID-19 using both the cohort and test negative designs. And you will see examples of both today. I will start with this recent study in which we looked at effectiveness of boosters, specifically mRNA boosters. And here is the slide for Pfizer vaccine. And here we compared the effectiveness of Pfizer, of those who had the booster, that is 3 doses, to those who had only 2 doses. So here is the Kaplan-Meier curve. As you can see, there is lots of incidence in both those who got 2 doses and those who got 3 doses. We had many vaccine breakthrough infections because of Omicron immune evasion. However, there is a very clear difference between those who had only 2 doses, which is here, and those who had 3 doses, which is here. In fact, we had almost 50% reduction, actually 49% reduction in incidence of infection among those who had the boosters compared to those who did not have the boosters. So this is for symptomatic infection. But I think even a more interesting result relates to the protection against hospitalization and death. where we saw actually a protection of almost 80% for boosters relative to 2 doses. And I just want to stress here in this study, we are comparing boosters to 2 doses. So those who got the boosters had actually so much more protection against hospitalization and death that basically made it very unlikely for them to end up in hospitalized or with death due to an Omicron infection. And this is really one of the general results we have seen now in a series of studies, that recent booster vaccination is very strongly protective against hospitalization and death, making it really just a theoretical possibility. Someone with a recent booster will end up with a serious disease in hospital. So this was the result for Pfizer. Here is the result for Moderna. We saw very similar effectiveness of about 50%. It was slightly higher, slightly lower for Moderna, but this is only because Moderna 2-dose vaccination is stronger than Pfizer, and it's more durable. So this is why we saw less difference between those who got the booster compared to those who got two doses. So this was comparison of those with booster to those with 2 doses. Now I would like to show results about the duration of protection, but here I am comparing to those unvaccinated, And here also I would like to show results for each of BA.1 and BA.2, because we had both of these subvariants transmitting during the Omicron wave and almost at the same time. These results are done using test negative design, case control design, as opposed to cohort design. So here is a summary of what we saw for BA.1. In the first 3 months after the second dose, the effectiveness was at about 50%. Then it declined to about 10% in 4 to 6 months after dose 2. And then it was basically 0 thereafter. So we saw very, very short duration of protection for Pfizer against symptomatic BA.1 Omicron infections, which is very similar to the results we just saw, also especially by Andrew, who actually used also similar study design. However, once people got their booster, effectiveness went back to where it was right after the second dose at about 60% protection in the first month, but then it waned again in the second month to about 40%. So this is really the story. We keep just seeing very short duration of protection for the mRNA vaccines against BA.1 Omicron infection. Really, protection against infection doesn't really last long. This was for BA.1, but we saw essentially identical results for BA.2, which also agrees with what just Andrew presented. It's exactly the same pattern against BA.2, very rapid waning after the second dose. Then we gain the effectiveness back after the booster, but it also appears to wane again, starting from the second month. So these are results for the duration of protection. And again, effectiveness relative to those unvaccinated. Now we have lots of interest in looking at different forms of immunity. So now I will move to show some of more recent results, which compares protection prior infection, vaccination, and hybrid immunity, including, I mean by hybrid immunity, including protection, natural infection, and protection of vaccination together. And these results will be also for each of these subvariants separately. This is also using a test negative design. So here is a summary of what we found for BA.1. For those who had a prior infection, and on average, those had the prior infection a year earlier, a year ago, they were protected at the level of 50% compared to those who were unvaccinated and never had a prior infection. So prior infection a year later is associated with 50% protection against symptomatic BA.1 infection. Now, moving to those who only got 2 doses, And on average, in our population, those who get the 2 doses, they get the last dose at more than 8 months earlier. So well beyond the duration of protection against Omicron. And not surprisingly, we saw an effectiveness of 0. And it's really very interesting, the contrast between prior infection, natural immunity, and vaccine immunity. Vaccine immunity against Omicron wanes very rapidly, but not natural immunity. Still, natural immunity is not very strong. We saw much higher protection for natural infection against Alpha, Beta, and Delta, which was around 90%. Here it's only 50%, but still, it's definitely more durable than vaccine immunity. Now, what if we combine 2 doses and prior infection? The protection was at 52%, very similar to the protection of only prior infection, which makes sense because really having 2 doses 8 months later, there is no really vaccine immunity against symptomatic Omicron infection. So it's really, this effect reflects just the protection of only prior infection. Now, what about 3 doses? For those who get 3 doses, and most of them got those doses recently, the protection was at 60%, which is similar to the result I have been showing you earlier in the earlier studies. And so it's clearly recent booster vaccination is very protective against symptomatic infection at 60% level. Now, what about combining 3 doses, booster with prior infection? So here, interestingly, we saw an effectiveness of about 75%, which is the largest protection we actually see. So we see a very clear signature that hybrid immunity of natural infection and recent booster vaccination is really very protective against symptomatic infection. And this is really the highest level of protection we see. So definitely there is value in vaccination, even for those who actually had prior infection. These results were for BA.1. We saw essentially identical results for BA.2 as well. The same pattern for prior infection, 2 doses, 2 doses prior infection, 3 doses, and 3 doses and prior infection. So just want here to highlight really how different are these protections. We had in these 5 different forms of immunity, we had a range of effectiveness between 0 for 2 doses and almost 80% for 3 doses and prior infection. This is the protection against symptomatic infection. What about the protection against hospitalization and death? And here I would like to stress that we define hospitalization, death. Actually, previous speakers really hinted at this. It's a very important point, how we define hospitalization and death. For us, we use the WHO classification for severe, critical, or fatal COVID-19. And the WHO classification is very, very specific. So this is not just a hospitalization. It's actually very specific to truly, really severe disease. So here is what we found. So despite the huge differences in the protection against infection between 0 to 80%, the protection against hospitalization death, there weren't really that many differences between these different forms of immunity. So now our confidence intervals are a bit wide, but still the result I think is pretty clear. There might be some differences, but they are not really huge. So this shows that any form of prior immunity, whether from natural immunity or vaccine immunity, is very strongly protective against really severe forms of COVID-19. This slide here shows the results for BA.1, but we saw very similar results again for BA.2. We are talking about really any form prior immunity is strongly protective against hospitalization and death. Now, this result is really very interesting. All of the results I've shown you so far are for Omicron, but we have been getting this message also earlier from our earlier studies with earlier variants. For example, earlier we looked at the severity of reinfections versus severity of primary infections. And we found that, and this was during alpha and beta incidents, that reinfections were 90% less likely to end up in serious COVID-19 disease than primary infection. So any prior immunity is very strongly protective against severe forms of COVID-19. Now, this result is really very interesting because there are evolutionary consequences here. If we look at other common cold coronaviruses, we see that prior immunity is strongly protective against severe disease at reinfection, and this immunity appears to last for actually even a lifetime. So we're not talking about really even short time, we're talking about perhaps lasting for a lifetime. If this proves to be the case for this new coronavirus, this is really good news for us, because it looks like with so much population immunity building up, especially after the Omicron wave, SARS-CoV-2 will adopt a benign pattern of infection, actually quite similar to the other common cold coronaviruses. We still will have to live with the pandemic, but really much of what really infections will be either reinfections or breakthrough infections among vaccinated persons, and these are much less likely to end up in serious COVID-19 disease. But of course, we have to watch whether really this immunity against severe forms of disease could be long-lasting or not. Let's hope it is, just like for other common cold coronaviruses. This brings me to my conclusions. The mRNA vaccines provide only moderate and short-lived protection against symptomatic Omicron infections, whether BA.1 or BA.2. Vaccine protection, however, against severe disease is strong and durable after the second dose and is most robust after the booster dose. Someone who gets a booster dose recently, it's really practically, they are extremely protective against severe COVID-19. And we really did not see hardly any differences in all forms of immunity, whether natural, vaccine, or hybrid immunity between BA.1 and BA.2. So last but not least, sorry, just copied a slide from another one where it was a recorded presentation. Anyway, I just want to thank the team for working on this and our collaborators. Thank you very much for listening.
Thank you very much. There's a question, how are symptomatic infections defined? What was the testing policy during the BA.1 and BA.2 period?
Yeah, so symptomatic, we have been since the beginning of the pandemic. Every PCR test done is associated with the reason for the testing. If it is because of symptoms, then it's called clinical suspicion testing. And this is how we define our symptomatic infection. So we exclude any other testing from these analyses, for example, for travel, even for contact tracing, for routine healthcare testing, and so on. So really, it's based on the reason for testing. This is how actually we defined it. Now, the PCR testing worked very well up to Omicron. The whole system got overwhelmed. So unfortunately, we had to, our policy was always to focus only on PCR testing. So during Omicron, however, with the huge demand for testing, it was by far our biggest wave. We actually introduced rapid antigen testing, and unfortunately, we lost the ability to track the reason for testing for the rapid test because it was implemented quickly. They could not implement this. However, all results I've shown you today are based on the PCR testing, where we were actually tracking the reason for testing and symptoms.
Thank you. I have a question to all the speakers. It's quite clear that the effectiveness against infection or symptomatic infections wanes after vaccination, regardless of the numbers. I mean, at least so far we have data for 3 doses. But what you showed here in the last presentations was a clear prolonged protection against severe disease. what are your thoughts about continuing vaccination? I mean, now we're vaccinating the very elderly with the 4th dose because those are most vulnerable. But I mean, if we see a very short-term immunity against just infection and transmission, I mean, a big question, should we continue vaccinate non-vulnerable populations? I mean, you're showing quite good protection still. And I was also related to that, I was wondering, Nick, I mean, you have large sample sizes in the UK. I mean, you should be able to stratify your analysis based on, for example, comorbidity status or immunosuppression, which I think is one group which is extremely interesting to look at. So it's a question for all of you, and then one specific for Nick.
So I mean, I can quickly start on that one. I did a stratification by risk status, and the VE pattern and waning looks actually very similar within the risk and the non-risk. I mean, obviously the overall risk of the severe disease is higher, but in terms of the VE, it's coming out very similar, which is encouraging. But yeah, I mean, in terms of the question about, you know, the protection, you do get a short-term increase, so you can. That would still, in the light of a big wave, potentially help in terms of keeping the overall infection down, or spreading it out at least, and keeping the hospitals less busy, perhaps. But ultimately, in the longer term, it wanes away. Over.
Yes, and sorry.
Please, after. Mm-hmm.
Okay, should I? Yeah. Okay, well, I agree with Nick, and it would be good. I think, as I hinted also, I mean, the important thing is, I think, to really look at the protection against hospitalization and severe disease. I think this is the clue to it. I don't think it will be possible to vaccinate away the disease as a common cold, and I mean, after the Omicron surge, I would expect that maybe 60, 70, 80% of at least the population in Sweden had COVID now. So I mean, we have I think the important thing to monitor is the protection against severe disease. That is what I mean, to think what we know now, I mean, as Nick said, during a short period, it might be possible to diminish the spread, to take it down, to really aim at that. I think we should have completely other types of vaccines affecting mucosal immunity in a different way than those vaccines we have now. We need very different vaccines, but I don't think maybe it's necessary. I mean, the important thing is to take away the serious disease, and I think maybe the most vulnerable groups may have to, and that is the important thing to see, have booster shots. And that is, I think, what we should aim at and monitor.
Really, I think it's pretty clear current vaccines are not best against Omicron-like variants. Their protection is moderate, and it really does not last long. If we really want to protect, especially those most vulnerable, we need recent booster vaccination. Recent booster vaccination makes really the possibility of very severe disease very, very unlikely. But the question is really timing. How can we actually time that? For example, if we have a wave starting, then this is exactly the time when people need to actually get their boosters, because otherwise the protection will wane very, very, very rapidly. However, for those who are not vulnerable, we see even 2 or 3 doses seems to offer really very, very good protection, not perfect, but really very, very good protection. So timing now becomes more sensitive. Really, current vaccines are good only when they are taken recently to virtually eliminate the likelihood of severe disease. We need really better vaccines, and we just heard from Frederik, very important point, mucosal immunity. The key difference between natural immunity and vaccine immunity is mucosal immunity. This is why natural immunity is doing better. So I think frankly, we need really new design of vaccines. We cannot live with current vaccines. We don't know, we may have other variants that could be far more serious. So we need really very broadly acting vaccines, pan-coronavirus vaccines, in order really to prepare ourselves for the future. Because clearly this virus is gonna live with us for a very, very long time.
Could I just add something totally different? So everyone are focusing on the individual risk of hospitalization and also mortality, but no one is talking about death directly. But that's also the point here, right? But we also have like infectiousness. So we have a lot of people working with elderly and immunocompromised people, both like you have home visiting nurses and social care people getting in people's houses, helping them bath themselves, etc. And we also have all these nursing homes. So a point could also be to vaccinate against infectiousness and not just about individual risk of possible people's for people's possibility of being exposed. And I think that's another point that is not being discussed.
So I see no further questions. I want to thank everyone for participating in this symposium organized by VACCELERATE. And especially I want to give a thanks to the 4 speakers for taking the time to present the data and the results today.